Okay, so here we go. We have a punch biopsy, and this lady had red, kind of violaceous papules all over her skin. And one of the dermatologists were called to look at it, and I won't tell you what they thought that it was because they were totally right. But I'll tell you that the internal medicine team saw it, and they thought it was going to be vasculitis. They thought it looked kind of like vasculitis clinically, which I think is understandable. So here's a punch biopsy, and what we have here in the middle is a hair follicle, right? So we are kind of almost a little collection of maybe 2 or 3 hair follicles near each other. And when we zoom in closer on that hair follicle, look what we can see is a cross section of the hair shaft, but not just one. 1, 2, 3, 4, 5. It's like a little multiple cross sections of a hair shaft with this dilated follicular opening. So what that implies to me is that the hair is kind of curling or twisting around a little bit, and we're getting multiple cuts through this twisted up kind of spiral shaped hair. And then in the dermis here, next to the hair follicle, we have red blood cells, erythrocyte extravasation. Lots of blood. Look at all that blood. Now sometimes it's hard when you see blood microscopically in the skin to know, is this blood real? And I put air quotes around real. Is this real, meaning is this an in vivo hemorrhage, like in the patient? Or is this blood that just spilled artifactually when the biopsy was performed? Of course, the blood is real. The erythrocytes are real. But is this blood actually present in the skin while it's in the patient? Or did this just spill out artifactually from the biopsy procedure? And one thing that can help is the clinical. If it looked violaceous or erythematous, looked red, looked like there would be blood in the dermis clinically, then it very well may be real blood, real hemorrhage. If you find hemosiderin with the hemorrhage, that's another sign that it could be actual in vivo hemorrhage, although you don't get that with acute hemorrhage, right? That's only with hemorrhage that's been there for a while. It's what happens when you get an ecchymosis, a bruise. The other thing is that this pattern to me of erythrocytes scattered and trickled in the superficial dermis especially, usually to me when I see that pattern of blood evenly kind of scattered throughout the collagen, or in this case the solar elastosis, because this patient was a little older and had sun damage, that usually to me is usually a pattern that you see with true in vivo hemorrhage, okay? So this is perifollicular hemorrhage and a spiral shaped corkscrew hair. So if you're not into derm path, you might be like, yeah, okay, so what's the big deal? But those two things are buzzwords for a relatively uncommon condition, or at least nowadays it's pretty rare to see in the United States. But in the old days, it used to be actually quite common. So this corkscrew spiral-shaped hair and perifollicular hemorrhage, I will show you the pictures now. And this part I may have to edit out because YouTube won't like this. This was the pictures from our patient, and there was hemorrhage and swelling of the gums, the gingiva, perifollicular hemorrhage, particularly on the legs, the arms also. You can see these twisty, spirally, kinked corkscrew hairs here. And then my former resident, Malin Kern, did a perfect biopsy right into the right around one of these hairs, and we got lucky that we got a perfect cut right through the middle to see this. So all these features together, this is characteristic of scurvy. So this is scurvy, and we, Malin and I, published this in the New England Journal of Medicine, which is the only thing I'll ever get published in the New England Journal in my whole career. I am certain of that. And it was really all about the pictures. We put 4 pictures, and like it was just a little single small paragraph. It was just an example of a classic clinical and path presentation of scurvy. And so this patient, they tested the vitamin C level in the blood, and it was close to 0. It was extremely low. The patient had reduced oral intake because of some esophageal problems, and they had been basically, I think, having a very limited diet for a long time that did not include vitamin C. So in the old days of wooden ships and in the days of sail, this was a much bigger problem because people didn't have access to vitamin C, and scurvy occurred. Nowadays, it's really quite rare, and I used to say, well, this is the only case of scurvy I've seen, but I've actually seen a couple of cases since this. None quite so perfect as this case here. The one thing I will point out, where did my oh, there, it just needed refreshed a little bit. The one thing I will point out, that scurvy classically has the corkscrew hairs and perifollicular hemorrhage, but not always. So I saw a case after this where a patient presented with painful, firm, indurated, like calf. Their lower leg was painful, and it was so painful as a teenager. The patient was basically like refusing to walk because it hurt so much. On imaging, there was some thickening and swelling of the muscle and the fascia, but they really couldn't figure out what was going on. And on the skin, there was no skin discoloration, no hemorrhage or anything like that. A biopsy was done, and they were concerned it might be eosinophilic fasciitis, which is something that's probably closely related to morphia or localized scleroderma, but involving the fascia and the fat, or at least I think of eosinophilic fasciitis as something like that. But microscopically, all I saw was hemorrhage around the fascia, nothing that looked like scleroderma or morphia or eosinophilic fasciitis. So it turned out, thankfully, the resident had, the dermatology resident had taken a photo, and even though there was no violaceous discoloration of the skin, there were twisted corkscrew-shaped hairs. And I said, I wonder if this could be scurvy. And sure enough, one of my colleagues did some searching in the literature and found there have been a few reported cases where scurvy presented with deep hemorrhage, which was really painful, and it caused induration and mimicked eosinophilic fasciitis. And this child was autistic and had very restricted oral intake, only ate like French fries and chicken nuggets or something to that effect, and basically had no fruit and vegetable intake. And they checked the blood of the patient, and the vitamin C was close to 0. So that case was really amazing to me because the hemorrhage was so nonspecific microscopically. It wasn't this classic perifollicular hemorrhage. It was deep hemorrhage. And they didn't have the typical presentation. And the reason I want to bring this up is in case anyone's watching this online, just to know that this is an alternative, unusual presentation of scurvy. And it was only if the dermatology resident would not have taken that photo, I would not have thought of it. The clinical photos sometimes save the day in dermatology. And also another case of scurvy, I'd seen a patient had known scurvy, and they had a muscle biopsy for some reason, and there was just hemorrhage in the muscle. And a colleague showed me that, and I thought, kind of boring microscopically, but that's interesting. It makes sense that they have hemorrhage since they have scurvy. So I had seen that case a year previously, and then the dermatologist had taken a picture, and I got to see the corkscrew hair. And because of that, and my kind of interest in scurvy from this one case where all the pieces came together and we got to make the diagnosis. And I thought those are those kind of moments where like good medicine happens. And it wouldn't have happened if it weren't for all of the people doing all of the right things and all the pieces coming together. So that's a great example of like how teamwork is really where it's at. All right, scurvy. So be on the lookout for it. I will say I do sometimes see hemorrhage next to hair follicles, completely coincidentally, that are clearly not scurvy clinically. I also sometimes see kind of twisted spiral-shaped hairs, and I like to joke about it with my residents. Oh, look, it's going to be scurvy, and it's like a melanoma excision or something where it's just an incidental finding. But do remember that scurvy is out there, and especially because there are fad diets. There are people that have low oral intake either for neurodivergent reasons or because they have a esophageal problem or had surgery. So there are a variety of reasons that people, even in developed nations, can sometimes be deficient in vitamin C or other vitamins and nutrients. So keeping vitamin deficiencies and things in mind is important, because if they're not diagnosed, they don't get better, and they're usually actually quite easy to treat for many of these things. You just give them the missing vitamin. All right, so that was scurvy. There was our New England Journal citation, and I'm still waiting for the Nobel Committee to call us. Probably won't happen, but it was a pretty cool case. Any questions about that? All right. So here is something that I've never seen in real life, and so I'm thankful to my friend Sadiq Amr he's from Yemen originally, but practices in Saudi Arabia. And I've never met him in real life, but we've been friends on social media for probably over 10 years now. So another great example of how social media can connect you with really great people. And he shared these beautiful images, and I'm so thankful that he allowed me to use these because I've never seen this in real life. So maybe you haven't either, but it's a pretty characteristic thing. So we have this. I love this one because it's like a volcano erupting out into this is in the nasal cavity. So this is the keratinized, the stratified squamous portion of the nasal mucosa here. And you can see there's a large sphere filled with multiple little dots that are pink on PAS stain. And then there are smaller spherules around here. And there you can see it involving the respiratory type mucosa. I'm just going to scroll through these images here and let you be amazed and swoon at the beauty of it. And that's my favorite one because it looks like a little crescent moon and some planets or something. So cool, huh? So anyone want to tell me what this is? Do you know?
The Rhinosporidiosis?
Yes, very good. Rhinosporidiosis. Excellent work. And again, something I've not seen in my practice. So that's because this is usually in the tropical parts of the world, particularly in India and Sri Lanka are the areas that it's well known for, but I think it can occur in some other tropical regions. So I think there's been some debate in the past about whether it's a fungus or not, but it's currently classified as a protist type organism. And this is, again, the only example I've seen. I post this online sometimes, and people from India have and other tropical areas have posted and said, oh yeah, we see this in our practice actually regularly. So it's, I think, always an interesting thing, especially with infectious diseases, to think about how geographic location really influences the way we think about our differential diagnosis, because of the incidence of disease, or the prevalence of disease, excuse me, affects the pretest probability, right? And the likelihood that we might encounter a certain thing. So if I show a picture of, say, granuloma annulare or anything granulomatous, if I look at that, it's, oh, that looks like granuloma annulare. But if I show that to colleagues or friends who maybe practice in the Middle East or in India, many of them are right away going to say, that's tuberculosis, or that's leprosy, or that's some other infectious disease, because of how much more often they see that. I do see mycobacteria in my practice, but it's pretty infrequent. I've never actually seen a case of cutaneous tuberculosis. Not a single case in my whole career or in my training. Only study sets, because it's so rare in the United States. So recognizing, travel history and geography makes a big difference, as you all know, for infectious disease particularly. Okay, great. Rhinosporidiosis.
Oh wait, can I? Okay, first of all, big fan, have to say.
Thank you.
Second of all, yeah, so I actually did a medical mission trip in Kenya, and it was a child who had a nasal polyp, and we were trying to FNA it, and it wasn't giving any cells. And then, so we took some back with us, and we processed it, and it was rhinosporidiosis.
Wow,
So I actually
amazing.
have, like, the gross photo. I even have, like, the cyto smears.
Really?
And I also have some pictures if you want.
Yes, if you would be willing to share those with me, I would be delighted to post those, give you full credit, and use them for teaching for future. If you're cool with it, just shoot me an email. That would be fantastic. What was your name?
Jasmine Vickery.
Jasmine. Thank you so much, Jasmine. Yes, I would be delighted to have those. I'm always looking for cool things to share for teaching, and I am, if you haven't figured out, I'm particularly fond of weird infections. I think it comes with like the derm path territory. We see a lot of infectious type stuff, and so so we find it kind of cool and interesting. All right, good. Thank you so much.
Absolutely. It was a tough case because I also had not seen it before until then. So.
Incredible. Wow. Okay, great. Let's see. Next case. Yeah, so this kind of turned into an infectious disease fest here. As I was going through, I was like, ooh, that's a good case. That's a good one. So we're going to get a lot of infectious type diseases in today's session. It wasn't how I planned it. It's just as I started finding cases, I was like, it reminded me of another one and another one. So here we are. So this is something you've probably seen before and heard of, but maybe a view that you don't typically get to see. But what is this little cutie? Or there's two little cuties here. Pretty pictures, but not pretty in your body. Like most things in pathology. Does anyone recognize these? I'll show you more photos. And if you have an idea, you can shout it out.
Giardia.
Giardia, very good. So does anyone know how did this preparation get made? I did not make this preparation. A really amazing mentor of mine shared this slide with me when I was a resident. Ashok Balsavar, who unfortunately passed away a couple years ago, but he was just such a wonderful man and a wonderful pathologist. One of my co-residents, Sarah Galfioni, liked to say he's a prince among men. And I think that was such an apt description of him. He's someone I never saw lose his temper. I never saw him like flustered. He was just always calm and kind. And I wish I could be at that level. My ability to deal with stress is not at that level yet, unfortunately. It probably never will be. This is Giardia. So anyway, how did this preparation get made? Does anyone know? It's kind of cool. You can do it in your own lab if you want. So this is a cytospin, okay? And what happened is basically a regular GI biopsy that ended up being Giardia had formalin left in it, and so Dr. Balsavar took the formalin and had it spun down as a cytospin, and then it produced this incredible slide where we get to see a much nicer view of the organism. So let me show you though some alternative stuff. So this is my post about it here on Kiko, and I've got some links to additional information here, and I'm going to show you a couple of those. So here is from my friend Daniel Skipper on Twitter, or X now. I'm still not going to call it X. I'm sorry, Elon. But it's always going to be Twitter to me. Just been doing it for too long. So this is maybe the view most of us are more familiar with, right? And I know I do skin and bone and soft tissue normally, but I still like weird organisms even in other places like the GI tract. So here's what we see in the small bowel here. We've got the villi, and then in between the villi, we've got the little fallen leaves, right? Kind of hanging out there in the space. So you got to always look in the spaces there, make sure you're not missing stuff. And that's the closer view. So you know, that's what I think we're used to seeing in pathology on a regular H&E. But a cytospin gives us this kind of image that's down here from the CDC, the flat view of the trophozoite, where you can see the two little, they look like little eyeballs, right? The two little nuclei or whatever they are. So that's pretty cool trick to get a nice pretty slide for teaching, if nothing else. But that's more typical of what we'd see in regular pathology practice. And then here's an example. This came from the Institute of Tropical Medicine in Antwerp, and was tweeted by Parasite gal, Bobbi Pritt, who is an incredible pathologist focused on infectious disease, parasites. If you don't follow her on Twitter or also her blog, which I'll show you in a second, you're missing out. She posts some wild, crazy, awesome stuff if you like infectious disease and creepy crawly stuff. So that's called the falling leaf type of motility. So that kind of that swaying, twisting motion from those little flagella there behind the organism. So it kind of propels them around. So this is why we don't like to drink stream water, because you do not want to get this, because it's bad diarrhea and cramping and gas and abdominal pain. All right. But they sure are cute, aren't they? All right, and then here's some more info. Again, you can check out on Creepy, Dreadful, Wonderful Parasites, which is Bobbi Pritt's blog. She does not pay me anything. I'm just a big fan, and I love to promote her content. I've learned so much from her over the years. All right, excellent. Any questions about Giardia? Okay. Okay, here's another GI biopsy, and this I had these pictures in the same folder as the Giardia pictures, and they have been long lost in my hard drive. And I was like, look at these great pictures. I need to bring these to the light of day. So you guys, dear residents, gave me the opportunity to do this. Thank you for so much of the best work that I've done has been inspired / forced by my former residents, fellows, med students, all my trainees who have been like, oh, please make this video, or please post this thing, or can you show an example of this? And otherwise I'd drag my feet, but for my trainees, I'm like, okay, I'll do it. And so without that extra push from all of the great, wonderful people that I've had the opportunity to train over the years, I would certainly have a lot less productivity than I do have. So thank you guys for inspiring me. Okay, here's a close-up view from the GI biopsy. You can see a little bit of, I think it was small bowel, I can't remember. A little bit of epithelium here, but really just kind of junk and mess, right? I'll show you one other picture. So this is the item. These are the items of interest here. What are these? Does anyone know?
Entamoeba.
Very good.
Red blood cells.
Yes, Entamoeba, right? Histolytica, they like to eat up the blood cells. And I always am worried about missing amoebas because to my eye, they look a lot like a histiocyte, like a really big histiocyte, except that instead of having a purple or bluish nucleus like human cells have, their nucleus is this kind of reddish color. So like a big histiocyte with a red nucleus. I think here's one, here's one, here's one, here's one. There's the fragment of one, and there's one there. So Entamoeba, there are several species. I think histolytica is the one that at least I learned as being most common. I'm not a gastrointestinal pathologist, but there are several species of Entamoeba. And there are some other amoebas, like Acanthamoeba, which can involve the eye and also involve the skin. To my knowledge, I've never seen, or at least not recognized, the case of cutaneous amoeba. It's possible that amoebas have seen me looking up at me through the microscope, but I just didn't recognize them. But hopefully not, because amoebiasis is a potentially serious disease. So I am always worried that because I'm like, gosh, in a really inflamed background, that would blend right in, and would be easy to miss. So if any of you find a case of cutaneous amoeba, I would absolutely love a recut or at least pictures because it's something that is, at least in my practice, exquisitely rare and I've not encountered in the wild that I can recall. So those are examples here. And again, fragments of probably degenerated red cells inside. So these are the trophozoite form of Entamoeba. Histolytica, probably. I don't know how to subspeciate the Entamoebas, but then let me see here, back on. Yes, so here's my post here on Kiko about it. And again, because Bobbi Pritt has great stuff, I found the content she had. Here's a tweet she had made about it, showing the Entamoeba cyst. So this is the different form. They have, this was Entamoeba coli, so they have a cyst form with multiple little, I guess, kind of baby amoebas in there, and then that breaks open, and then each of those grow up into the trophozoite form, and that's in the GI tract, and then through the feces, both the cysts and the trophozoites can leave the body, and then through the fecal oral route can contaminated food or whatever can infect other people. So gross, right? So here's her post where she explains this in more detail and some additional pictures. Oh, here on the CDC website, they have a nice amoebiasis life cycle. I find these oftentimes if I have any sort of infectious organism, especially one with a complicated life cycle, the CDC usually has a nice page that really kind of breaks down the life cycle and the geographic distribution of different types of diseases. Very, very great resource for infectious diseases. So I use their website a lot when I'm looking to remind myself of the life cycle of an uncommon infection that I don't see very often in practice. So what we're looking at in this is the trophozoite, and then Dr. Pritt's posts were showing the cyst form. All right, good. Any questions or comments? Yes.
In the chat, Dr. Montone shared a case of amoebic rhinitis. So it's in the chat.
Incredible. Let me pull this up. Amoebic rhinitis. Wow. Thank you, Dr. Montone. Cool. And you can see them. There's loads of amoebas there. That is crazy. Let me see. Will it let me go to the next? I gotta close. Oh, wow. That is amazing. I may ask you later if I can have permission to use these photos. If you want me to clip it out of the video, I can do that. If you're cool with me leaving it in, I would love to. And I would like to share the photos and post them more if you're cool with it. So just let me know your preference.
Sure.
No pressure.
Sure. This is a colonic biopsy, and I have a great endoscopy too, if you want to share. Sure.
Oh, yes. I'm going to start giving you guys lectures more often. It's like you guys reward me with more pictures and all sorts of cool little infectious presents. Thank you.
Yeah, and I can provide you the amoebic rhinitis. We published that. I published it with Lisa Rupert.
Oh, cool.
Wet cases. So that's an AJSP, but our case is probably one of the earlier ones. He probably had HIV.
Wow.
Anyway, they biopsied the sinonasal tract, and he passed away.
Oh, it's unfortunate. Yeah, that's definitely not a place you would typically think of, or at least not a place I typically think of seeing an amoeba infection. But wow, that's pretty wild. And what incredible pictures. Thank you both for sharing these. Thank you. Okay, so amoebiasis. Okay, and this is a case. Some images shared with me from my former colleague, Dr. Eric Rosenbaum, who's a pathologist with an interest in microbiology and specialization in microbiology. So he took some really nice pictures and shared these with me. So this is something that's relatively or quite common actually, but we don't always get to see a good example of it. So does anyone recognize what this is?
Is it some sort of louse egg?
Indeed it is. It is a louse egg. And there's a closer view. Doesn't this look like something like out of the movie Aliens or something? It's like a little alien all crouched up in there ready to just hatch out. And or like if you used to play, I used to play Half-Life, that video game, and the alien head crabs, they would jump on you and try to like attack your head, and they had like little claws like that. That's what it reminds me of. Super creepy and terrible. So this is a nit, right? The nits are the, if you've ever seen someone who has head lice, they're very common. You can see the crawling, adult and little tiny nymph or baby forms of the louse. And then the eggs get attached to a hair shaft. So this is the hair shaft here. And then this is the egg. And there's the embryonic, I guess, the baby louse in there getting ready to hatch out. This little door on the top, I think, is called the operculum, if I recall. It's like a little trap door to release the mite once it hatches. And then here it's kind of glued on to the hair shaft. It's really quite cool to see up close, but also disturbingly creepy. And that's a closer view of its little nasty little claws there. Ugh. Horrible, right? I hate it. And then if you're squeamish and you don't want to see a close-up louse, close your eyes. So there's an adult louse with its nastiness right there too. So pretty awful little guys there. And if you want to be more disturbed, I've got a video of a different type of louse, a body louse, which my friend Jorge Roman shared with me. And this is from an indigent care a clinic, and the patient was homeless and had body lice. So something I've not encountered in practice. Head lice very common, but I've not seen body lice. Very, very similar, but what's kind of cool about the video is you can see the blood in the GI tract and the peristalsis of the blood inside the GI tract of the louse. Incredible video he took with a smartphone up against a microscope in clinic. So you can see right there, which it definitely takes some practice to stabilize that, and he got an incredible quality shot here. And this is like a mineral oil preparation where the live louse is put on the slide, similar to what you do if you scrape for scabies. You can scrape off the skin surface onto a slide and put some mineral oil and then cover slip it, and then you can examine it under the scope with no stain and see the organism still living. So that's a pretty good example of that. Thank you, Jorge, for sharing that. Okay, so lice. Head lice, Pediculus humanus capitis is the head louse. So do not like them, nasty little things. Okay, any questions about lice before we move on? All right. So now we're going to transition away from weird infections for a bit and look at some other things. So this is just a really lovely picture of skeletal muscle, is it not? It's so cool because you can see the Z lines and the striations. You can see, I think, artifactually the tissue kind of pulled apart a little here and like emphasized the lines and the structure of the contractile filaments in the muscle. And you can also see, for some strange reason, the peripheral nuclei of the skeletal muscle fiber got lined up in this funny zigzag pattern. I'm not exactly sure why. I think it's just a funny artifactual cut, but I thought it was really cool. I'm easily amused and interested in interesting patterns under the microscope. I think that's what happens if you do pathology for too long. You get pareidolia, where you see, people see shapes in the cloud. I see shapes in the microscope slides. If it's happened to you, it might be too late to turn back from a career in pathology, but that's okay. I'm fine with it. So, but I also just am mesmerized by the patterns that we see under the microscope. So in any case, I wanted to share that with you because I thought it was fun. And there's a closer view. So cool that in the body where everything is so, curved and rounded and not geometric, we get skeletal muscle where you get like perfectly straight lines. And that's not, a common thing to see in an organic structure, So there's a reason here, not just to show you the pretty stuff. There's a practical thing that I'm showing here. So this is also skeletal muscle. And so, we don't see the striations here. Now, if you're a beginner watching this, or if there's anyone in your audience who's maybe a new first year, how do we know it's skeletal muscle? Because you can't just say, what tissue is this? It's muscle. You got to say what kind of muscle, right? Skeletal, smooth, cardiac. Those muscle types are in different parts of the body and can tell us a lot about where exactly the biopsy or specimen is coming from, especially if we're not given great information from the person submitting the sample. So that's always a good thing. Knowing your basic histology is really important. And so seeing striations tells us, great, skeletal muscle. But remember, cardiac muscle also has striations. But here I can't see good striations from this power. But how do I know it's skeletal muscle? Well, that's because there's peripheral nuclei, right? The nuclei, I know this is an exception here, but the nuclei are multiple and they line up around the outside of each individual skeletal muscle fiber. Also, the color of skeletal muscle is like kind of a deeper reddish pink than smooth muscle, which is like a pale pink. But I think that the shades of pink is quite nuanced and it takes some time to get good at that. So the reason I'm showing this is, what are these dark cells right here? I will show you some more pictures, and you can tell me what is happening here. What are these? Because this is a really important thing to know about. Now look closer, we can see the striations, right? Now you believe me? What are these?
Atrophy.
Yes, very good. Dark, hyperchromatic cells. When they're multinucleated like this, and you can see some striations, it's easy to tell, oh, this is skeletal muscle that's shrinking and atrophying, and when it atrophies, all of those many nuclei that it has in each fiber, all the nuclei along the outside, as the muscle cell, consumes its own proteins and breaks itself down and shrinks down to conserve energy, the nuclei come closer and closer and closer together, and eventually they overlap completely. And when you can see it happening, no problem. But when you get one like that, that can look a lot like a big hyperchromatic pleomorphic nuclei, especially from low power. And if you see that, and in the setting of a tumor, like sometimes tumors like desmoid fibromatosis, for example, infiltrates muscle, traps the muscle, makes muscle atrophy, and you can see scattered pleomorphism there and then think it's a sarcoma or something like that. So you may say, well, this is easy, but I've definitely seen times where it can be quite tricky. And I feel like this is something that sometimes people in pathology, as they're learning, struggle with. So recognizing skeletal muscle atrophy in all the different flavors and forms is really important. Because it can trip you up and cause you to make a mistake if you're not familiar with it. So I like to always point it out. So one thing that's very helpful about muscle atrophy is it's usually not by itself. You usually don't get one single skeletal muscle atrophy cell, because muscle runs in bundles. The fibers are all clustered together in a skeletal muscle bundle, like we see here, multiple individual fibers all clumped together. So when the muscle atrophies, even if it's not the whole muscle bundle, just part of it, you tend to see a little cluster of cells that are atrophied and in varying levels of atrophy together. Some which are totally crunched down and look like a smudgy, dark nucleus. It's really multinucleated, but we just can't see it. And then others where they still have some retained cytoplasmic contractile filaments. And it's important also to recognize this because guess what? These are going to stain with desmin. So if you think it's a tumor cell and you do desmin and it's positive, and then you might think, oh, this is a rhabdomyoblast. Maybe we have a rhabdomyosarcoma. I've certainly had times where I struggled because of entrapped skeletal muscle atrophy. I struggled to tell. I knew I had a sarcoma, but I couldn't decide, is the sarcoma making rhabdomyoblasts or are these just entrapped muscle atrophy? Because sometimes I've seen rhabdomyosarcomas that have entrapped muscle and had muscle atrophy. So the question became, is this really muscle atrophy only, or is there also rhabdomyoblastic differentiation? We have both. And it's been tricky. I've definitely had times where I've struggled with that previously. So recognizing it when it's real obvious is the first step. And then you can learn the more nuanced way of dealing with it when you're in the tumor setting. So I love how they're clustered together. And usually if you find it and you have a big enough sample, you can kind of track back from the cells where you're like, oh, I think it could be muscle atrophy. I'm not sure. And you look around and you'll start finding other cells near it that are more obvious. And then you'll find some striations. And then you'll say, oh, look, I can see it's connected up to this other muscle group. Okay, it's all muscle atrophy. Now, the flip side is that sometimes atrophic muscle looks different than what I just showed you. And it looks, instead of the cells getting really small and dark and crunched on top of each other, the muscle cells do get smaller and the nuclei come together, but the nuclei, instead of getting small and dark, they get big and have open chromatin and big nucleoli. So you can tell here there's some scar, I can't remember the setting here, some fibrosis. Here's a not normal muscle, but more normal muscle. And that you can see it at the interface here between the scar and the muscle, there's entrapped, damaged, unhappy muscle fibers. I don't know if they're really unhappy, but I like to think of cells as like little people and to ascribe emotions and feelings to them. Again, that happens if you do pathology for too long, but it's okay. I'm fine with it. So I don't know exactly why this happens, but my theory is that these are muscle cells that haven't like given up the fight, and they're activating and turning on gene expression to try to either like rebuild themselves or regenerate in some capacity, and that's why their nuclei expand and they get big nucleoli. But if you look around enough, you will eventually, especially in the setting where there's a lot, I feel like I see this more in like robust granulation tissue, tumor bed, re-excision. They had a surgery 2 weeks ago and now they're going back and taking more. I feel like I see this type of muscle change more in that really acute revved up setting of reactive muscle change. I don't know if that's true, but it seems like that's the case. I've never sat down and actually counted the cases, but I think it's important because these nuclei look kind of atypical, right? They don't look like normal skeletal muscle nuclei. They look big. They have, they're much larger than normal skeletal muscle nuclei. They have central kind of prominent nucleoli. The muscle cell gets this kind of amphiphilic color to it. Again, if you look around enough, you can usually find some striations. You can also see that the weird cells track back and they become more and more and more obviously. You know, here you might say, I don't know what that is. And then you're like, well, that looks like, oh, it's definitely muscle. See what I'm saying? As you track back, you can eventually find like the obvious muscle, which makes it more easy to answer the question. So just be aware that this is a kind of a different flavor of skeletal muscle atrophy. And it's one that I think is important because it looks kind of, you know, kind of funky and atypical. And if you just got one of these, especially like on a cytology specimen, you know, you might be tempted to think that this was an atypical or malignant cell, a multinucleated tumor cell, something like that. So, you know, I'm a big fan of learning all the weird reactive stuff because it doesn't seem very exciting. It's not something that, you know, people usually write chapters in books about, but it's something that's really important in practice because if you're not familiar with it, it can definitely trick you and you can make a big mistake. And the time to start learning reactive changes, whether it's granulation tissue or weird reactive epidermal hyperplasia mimicking squamous cell carcinoma or skeletal muscle atrophy, whatever it is, the time to start learning reactive changes is not when you're reading a frozen section and you're trying to decide, is this tumor at the margin or not, and they're going to go and take off part of somebody's nose or whatever. That's not the time to start studying. The time to start studying is when you have a boring excision specimen that you know is not a certain type of cancer, or you know it's reactive because it's an abscess. You know for sure clinically there's no tumor there. That's the time to look at just how wild reactive stuff can look. Look at how weird the vessels and the myofibroblasts look in granulation tissue. Look at how many mitoses there are in granulation tissue. Look how weird the skeletal muscle atrophy looks, or the reactive osteoblasts at a site of, you know, a fracture repair, where you know the fracture was from trauma because they had an ATV accident 2 weeks ago and now ortho's doing a procedure. So the times to learn are when you're like 100% sure that it's benign, reactive, inflammatory setting, not neoplastic. Study those cases and then it will help you to build that skill. It's something even 12 years into practice, even as a soft tissue pathologist, and a dermatopathologist, I still struggle sometimes with reactive changes in the skin and in the soft tissue. Even though I have a particular interest in this, I teach about it, I look at it, I still struggle with it. So you can never see enough reactive stuff. So there's my lecture for you today. It doesn't seem exciting. It may not be something that, I don't know if it'll get asked on your, you know, board exam. I have no idea what will get asked on your board exam. But the point is it may not seem something that's high yield, but in real life practice, very high yield. And the more comfortable you are with it, the better you are going to be enabled to avoid pitfalls. All right? And then that's back to the start. And then this is just a little bit of path art for you here. Look at that. Is that not gorgeous? This makes me think of like soap bubbles or something. The way it's like green and then pink, like how like a shadow or something. I don't know. Again, maybe I've been doing this too long. This is skeletal muscle, and it's not as dramatic, but you can see there's atrophy here because look at the fibers. They're smaller, right? These fibers are big, and look at how tiny And again, the atrophy tends to cluster together. There's a little atrophy there. I can't remember this I think was next to it, maybe an abscess or something. And we did this is a PAS stain with a green counterstain, which is quite lovely, isn't it? It's very pretty. So there's no fungus here. It was done for something else on a different part of the slide, on a big excision. And I was just like, whoa, I have never stained muscle with PAS, that's a green counterstain. And it just happened to have a really cool appearance. So I snapped some photos, and I just had to share them with you, because if you don't like that, I can't make you happy. Come on. Look at that. Isn't that amazing? You could hang that on your wall. All right. Any questions? Oh, wait, there's one more picture maybe? Oh, yeah. That's kind of nice too, because here we get, instead of the cross-section view that we had, now we get a longitudinal section, and you can see the striations, and you can see how, like, irregular the outline of the muscle is. It's like just so crunched up and very, very unhappy, I think. Pretty cool, huh? All right. I know you probably never had someone talk to you for 20 minutes about skeletal muscle atrophy before, but now you have. And next time when you see it, you're going to be like, maybe years from now, but you're going to be like, whoa, yes, this could totally have tripped me up. And you're going to remember this moment. And then you can send me an email and say, 25 years ago, you gave us a lecture at UPenn about skeletal muscle atrophy. And it'll make me feel like all of my my talking was not in vain. I hope that my kids do that one day too, with all the lectures that I give to them. I have 3 daughters. The oldest one's 12. So yeah, life is pretty exciting and fun and interesting. And I do lecture them about a lot of stuff, and they're like, ugh, Dad. But I like to think that one day they'll be like, well, Dad, remember how you said that saving money is a good thing? I've been saving and investing. So that's my hope. All right. Okay, let's see. Changing gears. So here is a little cool incidental finding. That is also quite beautiful, huh? Does anyone know what this is? I struggled to figure out what this was. I had seen this occasionally before, and I didn't know what it was. And it didn't matter because it was like, you know, skin cancer resection, and it wasn't at the margin. It was just a little incidental finding. But I wondered what exactly was going on here. Has anyone seen something like this? They're keratinocytes, but they're big. Look how huge their nuclei are. And they've got these big, smudgy, homogenized blobs of eosinophilic stuff in their cytoplasm. And then they've got some kind of chunkier keratohyalin, purple keratohyalin granules also. So there's one case. Here's a different case that I think is probably the same thing, although it looks a little different than the last one. Again, it's like up here in the granular layer, there's hypergranulosis, and there's these big blobs of pink stuff. And some cytoplasmic kind of clearing and nuclear enlargement. The nuclei are much larger than the neighboring keratinocytes. Look at those nice desmosome spines there. Isn't that pretty?
Is it some viral cytopathic change?
Ooh, very good. Yes, it is. It is viral cytopathic change. And I like that you recognize that, because it's not just about the pink blob, right? The nuclei are different. And a lot of times in virally infected cells, the nuclei get big. Even if the nuclei, you know, in herpes, we all know that you get herpetic viral change that affects the nucleus. But sometimes cells that don't produce that striking kind of viral cytopathic nuclear change, the nuclei get larger. So molluscum contagiosum is a good example. And these pink blobs could kind of resemble molluscum, I think. But molluscum wouldn't be a little tiny focus like this. It usually is invaginated. The blobs are even bigger than this. So I think it would be fair to think about molluscum here, though. It looks a little bit like those globules. But the enlargement of the nuclei, I think, is really helpful. So HPV, human papillomavirus, tends to do this. It tends to make large nuclei, usually with some pale cytoplasm, in the granular layer, in the skin at least. I know it's a little different in the mucosal sites. But so to me, when I'm looking for coilocytes in skin, I'm not just looking for a cell with a vacuole. These have vacuoles, but those are artifact. That's not coilocyte, because look how tiny their nuclei are. Coilocytes have large nuclei, and they do tend to have pale, grayish, or vacuolated cytoplasm, but the nuclei are large. They are usually located near the granular layer, so they're kind of paradoxically large, right? They should be starting to get smaller as they get to the granular layer, but instead they become way bigger even than the basal keratinocytes. So that really helps me when I'm trying to decide if something's a condyloma or something, or a verruca, and I'm looking for coilocytes. You don't have to have coilocytes for verrucas or for condylomas, but for condyloma, I do like to see coilocytes to be sure I'm right about the diagnosis. That's a topic for another day. I've got a lot of videos about about condylomas and warts. But basically, this is a little tiny flat wart, or a Verruca Plana. Now, it's not the classic example. I'll show you a classic one in a minute in case you're not familiar with it. This was an excoriation, I think an excoriated bug bite maybe or something. But this was just a tiny incidental focus off to the side. I'm always interested in like finding little incidental findings because, again, every once in a while that little incidental finding will be the only thing on your biopsy, and you might struggle to figure out what the diagnosis is if you hadn't studied that. But also, I'm mostly just because I'm a nerd and I like to find cool little interesting things to look at. So yeah, both of these I think are basically an unusual pattern of HPV viral cytopathic effect. So the way I learned that was my friend Cheal Cho, who is a dermatopathologist at MD Anderson, and I've known him since he was a resident. He published a paper a while back about eosinophilic homogeneous intracytoplasmic inclusion bodies in the setting of an unusual type of syndromic flat wart called epidermodysplasia verruciformis, or EDV. So in their case, they actually sequenced and found out that it was HPV type 49. Like with many things, it seems that there's never just one type of HPV that causes a certain thing. Someone will describe it, and then they'll say, oh, we've also found this and this and this serotype or virotype, whatever, of HPV that does the same thing. So I feel like the list of different HPVs that can make different types of warts grows ever longer, right? Think about the high-risk HPV. That list continues to grow, and it probably will grow and change as we modify the environment by HPV vaccinations, right? So it's kind of a never-ending changing pattern. But anyway, great paper here. And the ones that they show are slightly different than this, but I think that what I have here is basically a variation on this theme. In their case, they had a patient with syndromic EDV, which basically people have a germline gene mutation that predisposes in the EVER1 or EVER2 gene that predisposes them to be particularly susceptible to certain types of HPV, and then they get lots of little flat warts that have a very unusual cytoplasmic appearance. So normal EDV does not look like this. I'll show you what it looks like. It normally looks like this. The cells are HPV viral cytopathic effect, but they have this really expanded, very pretty gray-blue cytoplasm. So this is well known that in the setting of people with syndrome, they get this, but we also see this relatively often as little tiny incidental foci, little tiny incidental flat warts with EDV-like viral cytopathic effect in old folks. Like this is an old sun damaged person, you know, maybe next to a basal cell carcinoma or something. I see this incidentally weekly. I mean, maybe a couple times a week. And I really like it because I think that color of gray-blue is so beautiful. And HPV effect in the skin usually produces chunky, large, coalesced granules, like the granules all clumped together. So big granules in funny-looking keratinocytes. Think about HPV in general. So those are some examples of EDV. And then let's talk about regular Verruca Plana, regular flatwort. So to me, I think of EDV and this funny eosinophilic variation of it as basically subtypes of flatwort or Verruca Plana. Verruca Plana are not as easy to diagnose as regular Verruca vulgaris. Verruca vulgaris has, tall, finger-like papillomatous projections and in-towing of the rete. Verruca Plana does not have those things. Clinically, they can be one or sometimes multiple little tiny papules, barely raised, flat-topped. They can be multiple and kind of linear because if you scratch them, they tend to Kebnerize or grow along the site of trauma. And so that happens. Shaving can spread them, or people itching at them can spread them. And what they have microscopically is slight, gentle undulation, very vague, blunted papillomatosis of the surface, hypergranulosis, kind of a thickened granular layer, and then this pattern of HPV cytopathic effect. These cells people call bird's eye cells. I don't know why. I don't think they really look like the eye of a bird, but maybe I just have not looked at eyes of birds enough. So in any case, these cells that are kind of clear, have uniform, slightly enlarged nuclei with a little nucleolus, these are keratinocytes with this unique type of HPV effect that we see in Verruca Plana, also known as flatwort. So this is another example. That was a different case. Here's another case. I'm just showing a few examples. Here's one where you've got some Verruca Plana here, and then focally in that same Verruca Plana, you can see that blue-gray epidermodysplasia verruciformis EDV type cytoplasmic change. So regular flatwort Verruca Plana over here on the left, and then on the right, the EDV subtype. So they can coexist together. Isn't that nice? I just think it's kind of fun. And sometimes when you scratch or pick the skin, you get something called lichen simplex chronicus or prurigo nodularis. And it can also have some overlap. It can get kind of vacuolated, slightly enlarged keratinocytes, slight undulation, hypergranulosis. So sometimes I have trouble actually telling apart. When you've got good bird's eye cells like this, no problem. It's going to be Verruca Plana. But sometimes I see subtle changes that look kind of like a flat wart, but I think mostly it's just lichen simplex chronicus. Occasionally I'll say, oh, lichen simplex chronicus, but there are some features there that could also be a coexistent verruca. Like, because sometimes people have a verruca and they pick it. So then they get prurigo or lichen simplex chronicus change over it. It's very common in skin for us to see people pick and scratch at their skin. It's a common thing to do. All right. And we already did the EDV. So on these posts on Kiko, I've got more resources if you're curious about EDV and Verruca Plana. You can go watch. I've got other videos and examples there. All right, so the last case, and then we'll let you go. This is something I just happen to have some pictures of that I took a while back, and I realize I've never made a video about this, but it's kind of an important entity to know about, in dermpath at least. So this is called Acne keloidalis nuchae, or also known as a folliculitis keloidalis, because it's not really acne. So here's the clinical photo, and you probably have all seen this or something like it, just because it's pretty common in the population, usually in patients of African ancestry, because there are differences in African American or Afro-Caribbean or anyone of African ancestry. This type of their hair, the hair has a different density. There's a different number of follicles generally than in Caucasian patients, and the hair texture and growth pattern is a little bit different. And so it seems like that somehow is related to this process. So here's an example. These are pictures from Wikidocs. And so you can see multiple kind of scarred papules, often on the posterior neck. So that's where the name nuchae comes from. It's kind of a little bit similar to folliculitis barbae. I feel like there's some overlap with that, which you can have in the beard area, where people get kind of shave bumps and then those scar, and then the hairs get trapped and then they rupture, and then more inflammation and scarring happens. And it's the same kind of process that's happening here in acne keloidalis nuchae. And sometimes it can be quite terrible scarring and really disfiguring. So it's a really problematic disease for the patients that suffer from this. So I just want to give you the clinical context. So microscopically, there's a spectrum of changes we see, and all of those center around the rupture of hair follicles with varying amounts of inflammation and scar formation. And despite the name keloidalis, these can look kind of like a keloid clinically, but they don't actually make those big keloidal collagen bundles, at least none of the cases I've seen. So the keloid really is more in the name than actually in the microscopic slide. They don't expect to see big keloid collagen bundles. Here we have a hair follicle that has ruptured, and you can see naked hair shafts in the dermis with a brisk granulomatous reaction with neutrophils also. And then here is kind of the more late stage where you have naked hair shaft fragments, and see the pigment, that's melanin pigment. That's why hairs are darkly colored, because they have melanin in them. And then giant cell and histiocyte reaction around it. And that's just a little hair root over there, the matrical bulb of a hair. And here's another example where it's kind of more burned out and scarred, right? And you can see all this scar, some polypoid protrusion of the skin surface. The follicle is ruptured open with granulomatous and neutrophilic or separative inflammation. There's still part of the hair shaft in the follicle. Here's another naked hair shaft. And a naked hair shaft is a really good thing in dermpath, a good clue. If you see a naked hair shaft, that means at some point a cyst or a follicle, because many cysts in dermpath are actually of hair follicle origin. So it's not uncommon to see one or multiple hair shafts inside the cyst lumen. So if you see this, that means at some point in the past, a hair follicle or a cyst has ruptured open. Or the patient has had a wound or surgery or trauma that has broken up a hair follicle or gotten a hair shaft down into the dermis, okay? So that's useful to find this. It means something has happened here before. So these are all just examples. This is a more burned out example where you have dense hyalinized scar with naked hair shafts embedded in it and giant cell foreign body granulomas, because even though the body makes keratin, keratin is supposed to be on the other side of the basement membrane. Once it gets into the dermis, the immune system treats it like foreign material and goes crazy and kind of attacks it and creates this big robust response. And so here's like this hyalinized, burned out scar, but still some granulomas and keratin debris in there. If you saw this anywhere else as a single lesion, it could just be a ruptured hair follicle, a ruptured cyst. If it were in the gluteal cleft, you could say this could be a pilonidal sinus, pilonidal cyst, pilonidal tract. I kind of lump those together as pilonidal disease. If you saw similar findings in the groin bilaterally and they had a history of draining sinuses, it could be hidradenitis suppurativa. This whole spectrum of stuff I'm showing you goes along with rupture of hair follicle or cyst, which can be seen in a variety of different clinical presentations. So that is acne, keloidalis, nuchae. And if you don't know for sure the clinical, you can just be descriptive of it, and then they can figure out from the clinical setting which process. So if I had this and they didn't tell me any information and I couldn't get it, I would describe it and say this could be a ruptured cyst or follicle, but in the right clinical setting, this could represent acne, keloidalis, nuchae, but you have to correlate with the clinical dermatologic exam findings. So that's how I would word that if I didn't have access to the clinical information. All right. So that's the end of our kind of random set of cases. I hope you guys enjoyed it. Any questions?
Does anybody have a question for Jared? Please. Looks like nothing, and I don't see anything in the chat.
Well,
thank you so much, Jared. This was really good.
My pleasure.
Excellent. And and you have so much content available, which is all linked to all these websites. So I often go to those and just pull up some random cases, and they are pretty mobile friendly also. So you don't have to have a giant computer screen in front of you.
That's good. That's my goal. Well, I'll edit this and eventually put it on Kiko and YouTube with links to most of the pictures and things that I've referenced here, so that any of you who want to go back and study this in the future can go and look at it again if you need it. Well, thank you again, Zubair, for the invitation, and residence fellows, faculty. Thank you for attending and for having me. It was a real pleasure to visit with you today, and I hope you have a great weekend.
Thank you so much, Jared.
All right. Bye-bye.
Bye-bye.
Thank you.